Okay, so hi everyone and welcome to the webinar on surgical emergencies. We've got two great doctors, Ab and Fatima, who are going to be talking today. So I'll pass it over to Fatima to give an introduction.
Hey, hi guys. So if you've been tuning in for our weekly webinars, tonight's one is about surgical emergencies. So massive topic. I hope Ab will do a good job of allaying your fears about this.
Nah, mate, it's all over.
So yeah, just if you haven't seen us before, Avarus is a F4 doctor currently working in Northwest London. My name is Fatima. I'm also an F4 doctor, also working in the same area. And today he's going to be giving the talk. I'll just be kind of offering support, asking the questions. Based on your previous feedback, you've said you've wanted more kind of polls, and we've tried to organize that behind the scenes in various ways. We're going to trial this way today. So if you've heard of Kahoot, you'll know how it works. If you haven't, it's really, really simple to use. So if you want to join in with that, you can. So join on the website. The information's on the screen now, but in case you're just listening, so it's www.kahoot.it, or alternatively with the Kahoot app. And there's a code on screen now which you need to enter the game. So it's 9695760. And if you log in, then you'll be able to take part in the questions, and throughout we'll have a couple of questions scattered around, and Ab will let you know the results of those as we go along as well. So I'll hand it back over to Janvi, I think.
So just a quick shout out to our sponsors at MDU. Don't forget before starting your F1 year to fill out your MDU membership. If you've already have a student one, don't forget that this will run out in summer, so it's essential that you have indemnity cover. I'll put some links if you have any questions for the MDU. And just so everyone knows, at the end of the session, just before the Q&A or just after, someone from the BMA will be joining and just giving a shout out to the help that they offer as well. And then we go to the giveaway slide.
Sorry, I was getting into the names popping up already on Kahoot, but go ahead.
So just quickly before Ab starts, I'm sure you're all very keen for that. We just wanted to give another shout out for our courses on mindthebleep.com. So we've got a giveaway to win a membership for our Sweet and Salty course. So don't forget to fill that out as well. And the link is on your screen now. Okay, I think that's everything from me. So I'll pass over to Ab to get started.
All right, guys. Hello. Okay. Right. So let's just pop on this. So we had a couple more people going. How many do we have joining so far? So many. We got Iguana over here. Basil's popped in. We got some emoji faces. EJ the DJ. Lidocaine to soothe your pain away. Gangrene. It's like you guys want to talk about different things. I love it. Okay, so hopefully Janvi can pop the code onto the Facebook Live stream so that if people pop up later, they can have a chat. The reason we hadn't popped this in before is just because there's a delay between our Zoom call and the Facebook Live stream of like 30 seconds. So it means I can't really assess how well I've been teaching you guys because I have to wait like a minute or two after the slide. What I can do is use this to assess what you guys are thinking beforehand. So on the mobile, it'll probably pop up just before I start talking about the fact we're on the next question. You have around about 15-20 seconds to answer it. Don't take the 2 minutes. I'm just leaving that to give me time. And then we'll go through the answers afterwards. And this is more just to get you in the mindset of we're thinking about this, we're talking about this, just so you start thinking about the right the next topic we're going to be going on to. In terms of the contents, so we're going to start off by talking about the scope of this thing, because surgical emergencies is huge, and I do not have the ability of going through all of it in an hour and actually giving you anything meaningful out of it. We'll be talking about some the A to E stuff, the airway emergencies, which is there's two that I can think of that are surgical that I'm going to tell you about. Head injuries, which is something that a lot of F1s that are on the medical wards deal with. Abdominal stuff, not just gen surge, but the vascular neurology stuff as well, and just generally the stuff that an F1 on the ward that's medical might see in their patients. So, right, let me start up. We have so many people. Okay, let's start this thing. So question number one is, which one of the 4 conditions that are going to pop on your screen are can kill a patient first? Can kill a patient the quickest. And while that's going on, let's talk about the scope of this thing. So what I want to start off by saying that this is mainly for the medical doctors that are going to be on the medical ward. This isn't for the surgeons. Doesn't mean they can switch off, but I'm not going to be going through the surgery aspect of these things. I'm going to be trying to equip the medical doctors to know when they need to contact the surgical team, which surgical team to contact, and what to do before contacting them. It's going to discuss terms that they're going to be using in their referrals. I might also tell you a little about the initial management stuff to do with these conditions, just so you can keep patients stable whilst you await a specialist review. Also, F1s, I think, are more likely to do ward cover than clerking. And generally, when they do clerking, they shouldn't be given the complex cases. They should be given the bog standard when they just need someone to actually do the clerking. As well as that, in my experience, the regs generally post-take the F1s patients the fastest, and they'll pick up any issues or pick up the fact this needs to have a surgical referral in there as well. So I'm not going to discuss much on the diagnosing of it. I'm going to be going on the mindset that you're having a medical patient with a medical problem and they have this surgical pathology pop up during the middle of their admission. I'm not going to go into trauma because that's its own thing, and you shouldn't be attempting to beat your patients. So I'm not going to go into trauma. I'm not going to go into kids because peds is its own specialty, adds a whole load more surgical emergencies and most unwell patients need senior support. So you'll be calling your boss in for them. So I'm not going to get into that either. Finally, nothing about burns. Patients are mildly flammable, but if you test this, then it's generally frowned upon. So we're not going into burns either. Okay, so we're gonna, what's the time on this one? And it's done. So the responses are, so these are the scoreboards for the moment. I'm going to keep popping them in and out because I like it. But yeah, B and Taz and Egg are currently leading the thing. Yeah, by the way, the correct response was the airway emergencies, E. So A to E. I want to start off by saying that in most cases, you'll have time to do an A to E when you assess patients. Patients are a lot better at keeping themselves stable than I gave them credit for when I left med school. I thought if it's an emergency, they're going to get unwell really quickly and they're going to die really quickly. You have time to do assessments. And the A to E also helps buy you more time because it goes in the order of things that are going to kill the patient, and you'll start doing things to address it to protect them. Okay. You'll learn that unlike in the movies, people don't run for medical emergency calls. Cardiac arrest, maybe they do, but medical emergency calls, people don't run for them that much. So you'll have a little bit of time after you put the call out to do something. And it's probably better than just twiddling your thumbs if you do start the A to E and start trying to stabilize the patient. You should be familiar with the A to E assessment. It's on the page there: airways, breathing, circulation, disability, and everything else. I'm not going to go into that right now. There's a whole host of resources out there that can help with it. Paramedics use it as well, and it's part of ATLS and what have you. So I'm not going to go through that one. You can go through it on your own time. I'll just be pointing out the stuff you need to pay attention to. And your first job as an F1 is to be safe. Your second job is to learn how to be a good doctor. And I'd say the third one is to help other members of the team. And someone that's able to run an A to E before attempting to refer to their own senior is miles ahead of someone who just calls up the reg saying, I'm concerned, I don't know what's going on, I haven't quantified anything. The one that's already done something, assessed something, maybe had some sort of management plan going already, they're going to be of more use to their seniors. So, question 2. After securing the airway, what's the next part of the assessment? Let me see if I can start the question up here. Fatima, are you around?
I am, yep.
Hey, Fatima. So after securing, head injury patient, right? After securing the airway, what's the next part of the assessment when a patient falls on the ward and hits their head?
I know
What are you
you're
thinking?
trying to catch me out, Ab.
Oh yeah, you may have seen this before, but don't. But we're gone. So the options are breathing/rest, C-spine, assess the skull, or do a full cranial nerve exam. What are you thinking, Fatima? What are you thinking?
I mean, it's an A, B, C, D, E. So after airway, obviously,
Say it.
B stands for breathing, but it's head injury is a bit different. So
All right, guys. So spoilers. We were hoping that Fatima would get them wrong, so that people
no,
are
I'm not.
confident getting them wrong. But Fatima's
I
chickened out
refuse
herself.
Well, people are not going to trust me. I'm doing next week's webinar, so.
Oh yeah, that's true. They need to. She's a good doctor. I promise you. I promise you. Okay, let's go to the next part, the airway emergencies before we get to head injuries. So there are two. Thank you, Fatima. I'll call on you again in a second. So there are two scenarios that I think there are A issues, and these are the ones where you probably need to get something going before the Met call would arrive, because they're very time dependent. They're also both in ENT, so it's very specific to that specialty, or if you're covering ENT as part of Gen Surg. Two things. So you can see on the image there's a surgical scar from a thyroid surgery. So post-thyroid surgery, if they have a bleed, they can have something called an expanding hematoma, which means that basically they're just bleeding out into the space in the front of their neck, and that's going to slowly start compressing on their airway. You might so you'll notice stridor, they'll be quite distressed, late stage, hypoxic, blue in the lips, and what have you. When you start seeing signs of respiratory distress, that's when you need to relieve it. So you should have been calling the reg when you noted it, because the reg needs to get in, because the way to fix this is surgically exploring the wound and stopping the bleeding. But when you notice the airway compromise itself, you cut the sutures, open that area up to allow the blood to come out, put a loose dressing over it just to try and absorb some of the blood. Don't put much pressure on it, because you don't want to choke them yourself. And you wait a reg to come along so they can be assessed and taken to theaters in a matter of urgency. It's very rare for that to happen, though. I haven't had it during my 5 or so months experience in ENT. The other thing, even less likely to happen, is a torrential bleed post tonsillectomy. That's a primary bleed. So they've had the tonsillectomy and they have a massive bleed. You get them sitting forward, you get them spitting out the blood from their mouth so they can still try and keep breathing through their nose. And you call the reg. In this one, you can do the A to E as well. And just keep in mind for C, if they lose a lot of blood, you'll want to try and replace it with some blood or some fluid to stabilize their observations while you wait for them to be taken back to theaters. For small bleeds, reg is probably cauterized on the ward, not to worry about that. Those are the two things that I think you may not have time to do a full ATE on before you need to do something about it. Right, so head injury. Right, what have we got for the results? So 51 said breathing arrest, 48 said C-spine. So I think 51 of you guys fell for Fatima's trick there. With trauma, C-spine goes just before breathing, because if you're moving the neck around and you pull on it accidentally and you sever their spine, then they stop. Well, it's a problem. They can stop breathing or breathing correctly, or paralysis and what have you. So C-spine is the next thing that you protect after you protect the airway, and then you go into breathing. And the current A and E. So the emergency guys are doing well right now. Let's go into head injuries. The one trauma I'm going to discuss here is head injuries, because it can happen. Falls can happen on the ward with slippery socks they have. They're attached to catheters. It catches something. They're old, peripheral vascular disease, can't figure out where their feet are. Sometimes in F1, specifically overnight, you're going to be asked to assess them and go from there. My part of the talk is really going to go on talk about what happens if there's a bleed or if there's decreased GCS. If you're most hospitals have their own proforma. And if your performa an examination indicates they're fine, there may also be some administrative stuff you need to do, like risk assessments for why they fell and how we're going to address that in the future. But that change between trusts, I'm not going to get into that. So you get called to see a patient overnight, they fall, what do you do? If they're on the ground and they're able to get up or they're getting up themselves, get them on the bed so you can assess them. If they can't get on the bed or they haven't tried to mobilize and they're still on the ground, then you need to clear their C-spine before you get them on the bed. The way I use it is something called the Canada C-spine guidelines. It's on MD Calc. If you do Canada C-spine, it'll be there. But one of the first things that stops it is if your patient's aged over 65, which is going to be a lot of your patients. Your own performers may have different risk stratifiers that say, does this patient need a CT scan of their C-spine or not? If you can clear the C-spine, good, makes life easier. If you can't, you need to keep the C-spine immobilized. The way that I was taught this when I was in A&E is, let's say the head of the patient's here, the body's further up, and I'm at the head of the patient. I take my hands and I grab their traps and I use my forearms to squeeze their head between my forearms, and that keeps them stable, and I stay like that. If you can get one of the nurses to do that, that's really good because then it frees your hands up. And then you need to get some blocks there, which are these orange blocks that you put on the side of the neck, and you tape it there so they can't move their head around. And while you do the rest of the stuff, I'm not going to go how to do the C-spine checks because it takes another 5 or so minutes. But you can look up online in terms of YouTube stuff how to do that. Let's say the C-spine's clear and you're assessing them in the bed. Next thing you're doing is looking for signs of basal skull fracture or depressed skull fracture. Assessing the GCS and comparing it to their baseline. So if their GCS is 14, but they're always, because they're confused and they're always a little bit confused, that's not off their baseline. It's not too bad. Assess for loss of consciousness and seizures, and see if there's any other indications for a CT head. NICE have put out a really good flow chart that indicates who gets a CT head, and also within what time frame, within 1 hour or within 8 hours. And it's based on stuff like, are they on anticoagulants and stuff like that. So go ahead and have a look at that. That'll help you out. If when you get there, the patient's unstable, so the GCS is less than 8, or there's really abnormal breathing, I would class that as an emergency. So you need to put an emergency call out that makes sure an anesthetist gets there or an ITU guy gets there. Sometimes met calls in hospitals don't have an anesthetist or someone that can intubate come along to the call. So make sure you put out a call that gets your anesthetist there so you can protect that airway. You probably also want your bosses there as well, because once they get the airway in, if they've intubated, then they might need to go on ventilation, which means you need to have a discussion of how far are we going to go with this patient. Do they go to ITU or are they ward-based ceiling of care? So after you've gotten someone to put that call out, you're going to want to put some O2 on them with a mask and do a jaw thrust. You can't do the head tilt just because you're trying to protect the airway. So what you do is you put the pads of your hands onto the patient's cheeks like so, and then you wrap your fingers around their head like the face hugger from Alien until it goes behind the ramus of the mandible, and you just pull it forward. It's painful, so if their GCS is more than 8, they may wake up and they may slap you around, but if it's less than 8, then you're helping keep their tongue out of their pharynx. If there's no indication for CT head, good, fill out the rest of the forma, document, you're done. If there's a CT head indicated and the patient's stable, or there's concern regarding any sort of brain bleed, inform your senior, get a CT head done, and then refer it to neurosurgeons. Okay, so the 3 outcomes: patient's really unstable, put out a met call because you're gonna need someone to secure the airway. You're gonna need the bosses to come in to make a plan. Patient's stable and they don't need a CT head, fill out the paperwork, you're done. Patient's stable, but they do need a CT head, get it done. If there's a bleed, refer to surgeons. Next one goes peritonism. Yeah, we have already done this one. The next one's going to be later on, so we're not going to go into questions just yet. So, peritonism. Now, this is a word that's thrown around a lot, which is kind of used interchangeably for pain in the tummy. It's not that. A general surgeon doesn't like it being used for that. It has specific meaning. Peritonism can be localized or generalized, and that really affects the layer of the peritoneum that's affected. And you're looking for 3 things: guarding, rebound tenderness, and board-like rigidity for it to be peritonism. So with the guarding, it can be localized or generalized. Specifically, it'll be if there's a specific organ that's being hurt, that'll be where the guarding is going to be around. If it's gotten extensive enough, it's gone through both layers of peritoneum. And it's involuntary, which means that if you're distracting them, talking to them about their day or what have you, and you're just being very gentle and going in there and they're not tensing, then that means that they were voluntary guarding beforehand. It's not the same thing. Rebound tenderness. So classical way of doing it, press in, hold a bit, pull out, see if it hurts more, talk them through it. And very mean. My bosses say, you know what, percussive tenderness is pretty sensitive for that as well. Just put your hand over there and just do a little bit of percussing over that area. If they find that painful, then you can use that interchangeably with rebound tenderness. It's less mean too. And board-like rigidity. So a lot of the time, when I was in gen surgeon, I got referrals from the ED or what have you. The patient would be said to have been peritonitic in a great deal of abdominal pain, and I can see them from where they're referring it, and they're writhing around. If they're writhing around, it's probably not peritonism because you're trying to protect your viscera by not moving. You become stock still like a board. If they're writhing, it's probably ureteric colic or something retroperitoneal or something like that. Or it's not true peritonism. These aren't be all and end all, but that's the general gist of things. If you see a patient and their stock still not moving, they have difficulty getting up from the bed and stuff like that, that's something that surgeons find concerning. Why is this even important? Because when you use this word peritonism to a surgeon, it indicates there's some sort of emergency that they need to care about. Perforations, going to have peritonism generally. Complex issues, going to have peritonism. So when you, in your referral, when you say peritonism, we treat it as it's important. There's this image, basically, so you might have difficulty seeing this on your phones, but if you just search quadrants of the abdomen differential diagnosis, it says that if you split the abdomen into 9 different parts, the organ underneath it and just to next to those sections as well is probably going to be the cause of the pain. So if it's the right upper quadrant, gallbladder, biliary system, right lower quadrant, appendix, left lower quadrant, diverticulitis. We'll come through that in a second. Thorax. So at this point, we're now basically just going down the body. Thorax. A lot of stuff can go wrong in thorax, and it's pretty catastrophic. But generally, people present with them rather than they have them happen during their admission. So I'm not going to go into them too much. With stuff like breast abscess and what have you, I'll go with that when I talk about breast. The only thing I want to say surgically about, I'm not going to go into pneumothoraces and stuff like that. The only one I'm going to go into is an aortic dissection, which is a vascular issue, because it's good at mimicking an MI. The difference is it's typically a tearing pain, but it can still be sharp. Progressing, so initially it's retrosternal, and then it progresses to the back as the tear continues down the aorta. As the tear happens, it can compromise the vessels that come off it, so it could compromise the blood supply for the arm, so there'll be paresthesia or what have you with that. That's pretty late sign when that happens. Difference from an MI, it's immediately worse rather than MI that's a more worsening pain. But with both, you still need to do an ECG because an aortic dissection can still involve the coronary arteries, and they could have an MI at the same time. The reason this is important is because with an MI, you think about thrombolysis. With an aortic dissection, you don't want to do that. So if you're thinking, is this an aortic dissection going on instead, have a chat with your bosses, because the management stuff is going to be stuff like medically lowering their blood pressure, which is not something that you normally do, and it's something that needs monitoring with ITU and HDU, and they'll need to get a CT scan there, which they don't normally get as part of an MI pathway. So if you're thinking it's that, have a chat to your bosses when you get a chance. So the sooner the better, really, as soon as you do your AZ. And like I said, breast I'll talk about there. Okay, question 3, fingers on buzzers. Fatima, I'm going to call you back again if that's okay. Hey Fatima, I love that smile. So this time we're going to be talking about hernias. What I want you guys to think about is hang on, let's get the question going. What is the most common hernia for a woman to get? Fatima. Now, I know you were mainly trauma and ortho back in Ealing when we were working there, but you did some time in Gen Surg. Which one do you think is the right one? Can you see the questions?
I don't actually have the question up.
All right, so options are femoral, spigelian, inguinal, and lighter. What do you got?
And what was the last one?
Lighter, L-I-T-T-R-E. It's Meckel's diverticulum.
Oh, okay. I know you're trying to trick people again, because what do you want me to really answer you?
Mate, go for it. I mean, let's
see,
go. If you get it wrong, they're going to be so much more comfortable getting it wrong. Huh?
The thing is, because you always get taught at medical school, don't you, that like femoral hernias are more common in females.
Yeah.
But that's not the most common hernia they get.
Okay. So what is the most common hernia they get?
Don't act like you don't know.
I mean, I wrote this question for this very specific reason.
I assume that's your reason.
Yeah, fine. Okay, fine. We'll let you go without specifically answering it. But
because then what's the point, you know?
Oh, you gonna answer it then? Go on.
No, I'm not gonna answer.
All right, fine. Be gone with you. I'll get you for the next one. Oh dear. Okay, so hernias. Why want to talk about hernias? Are hernias an emergency? Hell no. But their complications are good ways of showing the problems that come about with bowels, and those could be emergencies. So might as well talk about them. What is a hernia? Viscera protrudes through a defect. So stomach goes up through your diaphragm, hiatus hernia. The holes of your deep and superficial inguinal ring are still patent, sadly, and bowel gets through it. Inguinal hernia. The wall itself, of the walls of the canal are weak, and it allows something to push through. Another form of inguinal hernia. It's all there. But do I particularly care about hernias as an emergency? No. What do I care about? So if the defect is large, as in the hole that it's come through is large, I'm not too worried, because a large hole means that less likely that any sort of twisting or what have you is going to cut off blood supply or something like that. It's more easy for it to be cut off in a blood supply in a smaller hole, which is why femoral hernias are more concerning, because there's a smaller defect generally that they can go through, and they have a higher chance of getting those complications. If it's been there for a long time, I'm not too concerned either, because if it's been stuck out for a long time, I'm not too concerned either, like years, because over time, the hernial sac starts getting adhesions to the wall outside, and so it's really tough to put it back in and keep it in. But that doesn't mean it's a problem. The problems occur when it first incarcerates, which means it gets stuck. And generally, new incarcerations are what concern me. That in itself isn't the emergency, but that's a reason to refer to surgeons. Strangulation. Some sort of flow in this tube has been buggered because of this. Either it's blood flow, so it's ischemia, or it's the poo and it's obstruction. Let's go through ischemia first. What happens is intense amounts of abdominal pain, specifically there, or maybe in the abdomen if the part just distal to the actual hernia part's has gone ischemic. They will probably get diarrhea because the parts distal to the hernia or the obstruction will try and empty itself. As the bowel dies, there'll be some blood involved as well. And even if it's been out for a very long time and strangulated for a long time, but you eventually calm the patient down and you pop it back in, if the pain doesn't go away with painkillers after 15-30 minutes, it still needs to be looked at by a surgeon, because maybe it's gone ischemic and it's going to just die because we haven't been able to reperfuse it in time, or the sac is still constricting it. So try and pop back in if it's popped out and stayed out very recently, but otherwise don't. We'll get to that's generally the same for a normal bowel ischemia as well, as in without a hernia involved. There'll be extreme amounts of pain, more than you'd expect with the pressure that you're putting on their abdomen. Don't trust them having a normal lactate, because a high lactate relies on the blood that's at the site of strangulation going into the into the rest of the blood supply. If it's stuck there and none of that lactate is coming through, the lactate's going to be normal. Doesn't help you. So don't trust a normal lactate. And that strangulation needs to go to theaters. They need to see if they can save the bowel. That's a time-sensitive emergency. The other one is obstruction. So with obstruction, maybe it's just poo. Maybe it's poo and air if there's a twist in the bowel. And again, what happens is the part distal to it peristalsis like crazy to try and get the bowels working again. Doesn't happen, but they end up having a large motion outwards. If they've got a good enough kink they can't get any gas through, then there's no flatus. So asking about flatus is important. And the stuff proximal to the obstruction is going to start filling up with gastric juices, even if they don't eat or drink anything. They swallow saliva and all that stuff. So it's going to start becoming distended. Their abdomen is going to become distended. There might be some pain involved. Eventually, they might start vomiting as well. And that's going to be what makes us think this is an obstruction. The vomiting, the actual not opening bowels or no flatus for quite a few hours, abdominal pain, distension, and probably some risk factors to allow it as well. A 20-year-old I wouldn't assume to get bowel obstruction, basically, but an 80-year-old with 5 or 6 abdominal surgeries in the past, far more likely to have that done. On the wards, with your elderly patients, if you're thinking they've had this, another thing you need to keep in mind is for elderly patients, a lot of them can get constipation and it can mimic obstruction really well. They can feel unwell, they can start vomiting, they can be distended. The way to assess it before your referral is to do a PR. You need to put a finger in the back passage, see if you can find any hard poo there. If you can, then put something up the back passage before you give them laxatives to try and open the bowel up. Okay. If it's a hernia there as well, and you think the hernia is the cause of the obstruction, then it's not really going to be able to fix it. But if it's just constipation with a normal obstruction without a hernia involved, try and open up from the bottom end before you do it from the top end. Because if it is an obstruction, so let's say the bottom end loosens up the poo goes out, but their symptoms don't resolve, they may still have an obstruction. And if you give them laxatives from the top end, you might cause something called a stercoral perforation, which is basically their bowels, peristalsis like crazy, go ham, and then they rip themselves apart, and then they have poo flying everywhere. So just do the PR first, check if there's hard poo in the back passage. If you find hard poo, if you don't find a hard poo, or you don't find any mass there either, then you can do an x-ray, abdo x-ray, because that's one of the few reasons to get an abdo x-ray is to check for obstruction. And you're looking for radiological signs of dilated bowel and what have you. Generally, it's going to be there. Generally, if and then with that, when you have that image, you then it could be pseudo obstruction, but you should probably still refer it to the surgeons, and then let them make that decision. They'll probably need to assess the patient. In the meantime, they'll probably advise you to do something called drip and suck, which is when you put a thick Ryle's tube down their nose, an NG, that decompresses their stomach so they don't have unsafe vomits anymore. All the fluid goes straight out there. It's on free drainage into a bag. You replace fluid back into them with IV fluids, maybe antiemetics. They still feel a bit sick. You can give them that IV as well. And you can consider, if they're doing really badly and they've lost quite a bit of fluids, you can consider a catheter to monitor urine output for strict input-output monitoring. With the fluids, don't forget you might need to replace electrolytes. They'll probably need to go into... So the surgeons need to decide, do they want to try therapeutic gastrografin? Do they want to take them to surgery there and then, or what have you? The adage is don't let the sun go down on a small bowel obstruction, but I'm not the one seeing your patient. They need to see your patient. They need to decide when that surgery happens. So that's why you need to refer to those surgeons. Probably let your bosses know as well, but the bosses don't need, outside of the advice, I don't think there'd be too much more that they'd add in terms of advice there. Infections, intra-abdominal infections. So that's why this image is important. So, like I said, it depends on the layer of the peritoneum being irritated as to whether or not they localize it. Right lower quadrant diverticulitis, right upper quadrant biliary system, left lower quadrant diverticulitis. Apologies. Right lower quadrant appendix. As a general gist, you do a history, you do an examination, you do the A to E, you give them analgesia. This thing about Don't give analgesia because it might change the clinical signs for when they assess it. No, you give analgesia. And IV fluids, and you refer to surgeons, and they'll probably ask for you to give antibiotics in the meantime, except maybe for appendicitis. They want to make sure it's a good going appendicitis and they want to take it out, but that'll be up to them. They might also want a CT scan to be able to find out the source of it. And they might also want a CT scan for the obstructions as well, because they want to find out where the cause of the obstruction is, but that's going to be for them to decide, not for you. That's not at your stage. Right. It's a good bit of chatting. Is there we're about to go into the next set of questions, just so we have a look at the last results. So femoral hernia, 48 of you, 27 said inguinal. So just so you know, femoral hernias are more common in women than men. That is true. But if a woman comes in with a hernia, it's more common for it to be an inguinal hernia than a femoral hernia. That is exactly what Fatima was trying to get at in terms of, I'm trying to trick her. I was, and I got 48 of you. Proud of that. Leaderboards right now. Oh, Piglet, you've gone into 3. That's cool. That's third position. That's great. That's great stuff, guys. Okay. Abscesses, lumps. This is where I talked about the breast abscesses, breast lumps, perianal abscesses, abscesses in the armpits, that sort of thing. With the breast, do not stick a needle in it if you're not sure if it's an abscess or not. If it's like between you're thinking it could be abscess or hematoma, don't stick a needle in it, because the moment that you do stick a needle in it, it goes from being possibly sterile to definitely not sterile, and you'll probably get an abscess out of it. And they have their own risk. They might need an incision and drainage. If it's just a hematoma, it might just go away on its own. So if you get a lump, assess it, A to E, refer to surgeons. If they're thinking it's cancer, they'll say send it via MDT. If they think it's infection, they'll see them during that admission. If they decide it's an abscess, or if an abscess is found anywhere really, perianal, under the armpits, groin goes to urology. Anything else, generally gen surg. Some hospitals, limbs are going to be orthopedics. So it depends on your guidelines there, on your local guidelines. But it's going to be a course of antibiotics. If they're tiny, maybe that's all they get. Otherwise, some sort of drainage of the abscess, either with or without an incision, maybe just a fine needle drainage instead. For abscesses to be different from cellulitis, it's not just a bad infection. There needs to be a point of actual fluctuance. It needs to feel like there's a liquid underneath. Just the boggy edema of cellulitis isn't the same thing. So you need to actually be poking at one point, generally the part that's sticking out, and be like, yep, that feels like there's fluid underneath there. It could be quite tense from the fluid, but it's still fluid. Question 4. Fatima, are you still there? Yeah, she is. Were you going to say femoral or inguinal for the last one?
Well, I like kind of I said you're trying to trick me. Femoral is more common in females, but it's not the most common for females.
Right. Well, you know what? Let's see if we can get you on this one, yeah?
I'm not going to commit to anything.
Oh, mate, commitment issues. Oh, not the first time I've heard that. So does the bilirubin have to be raised in cholecystitis? There's a nice little image there as well. But does the bilirubin have to be raised in cholecystitis? What do you think? Yes or no?
Well, cholecystitis is an inflammation of the gallbladder.
Uh-huh.
And bilirubin is, you know, if it's raised, it's an indication of, in this kind of situation, is blocked biliary tree ducts. But they are distinct things. Could coexist, could not. So,
well, the question is pretty specific. Does it have to be raised? What's your answer?
Well, no, but
oh, okay. We've got an answer. Your commitment is strong. I love it. We'll get to that in a second.
Yeah, you weren't leaving me alone, so.
Nah, not this time. Exactly. All right. And we'll make sure you throw a couple of those funny stories, because those later questions, I'm going to be asking those ones from you. All right, Fatima, be gone. We'll go over the answers later. Right. Thank you. All right, so biliary system. So right upper quadrant pain, cholecystitis, or could be ascending cholangitis or what have you. The important part, the emergency part of the biliary tree. So perforated gallbladder, sure, refer to surgeons. We'll check it out. If they're really septic, we should probably come sooner. But a patient, the thing I want to hammer home, a patient that has biliary obstruction with the stone is stuck there and the bilirubin's getting worse and they're febrile and it's the Friday and the ERCP guy is going to come in on Monday, you have to think, should they really be waiting 3 days for that ERCP? Probably not if they're getting worse and the obstruction is getting worse. So if you note this, let your bosses know so they can think about, should we be thinking about transferring this patient to somewhere that can do an ERCP over the weekend? That's the emergency. Is it specifically surgical? Yeah, maybe not. It's generally managed more by the medics, but that is there, and surgeons do love the biliary system quite a bit. For cholecystitis, I wouldn't class it as an emergency personally. It's just an infection, and it has the issues that goes along with that. Surgeons love ultrasounds for them. Overnight ultrasounds aren't available. Get a CT scan instead if they're quite unwell. Run it by your bosses because they might cost more. There doesn't need to be biliary obstruction of the CBD for it to be cholecystitis. It could be a stone that is, let me put my mouse there, just at the neck there. Now the bile is made up here and it travels down. It goes into the bile, into the gallbladder to hold it, but it doesn't make it there. It's made there. So if the obstruction is anywhere along here, they might have a slight raise in bilirubin, but maybe not that high. If they have it anywhere down here, they'll have a really big raise in bilirubin. And that's where the concern comes. Anything else? Cover them with antibiotics. Some hospitals for cholecystitis, they just give antibiotics, wait for it to die down. Surgeons see them in an outpatient. So that's why I don't class it as an emergency. If they're having quite a bit of abdo pain there, some peritonism too, you can always get an erect chest X-ray to look for any free air under the diaphragm. Not very specific, but it can help. Not very sensitive, sorry, but it can help to see if there's a perforation there. And surgeons get more involved if there's other complications like pancreatitis or what have you as well. Right, next one is bleeds. I'm not going to touch on upper GI bleeds. That's a medical issue. Generally, it's treated with medics because they do an endoscopy where they can find the bleed and treat it well. I'm going to talk about lower GI bleeds. Just so you know, for the upper GI bleeds, risk stratifying score generally done with the Blatchford score. So find that on MD Calc. In that, different hospitals have different guidelines on which cutoff they have for when they endoscopy the patient, based on their Blatchford score. For lower GI bleeds, as long as it's not straight melena, it generally goes to the general surgeons. That's us. You do a PR to check if there is an actual PR bleed ongoing. And if there's a mass causing the bleed in the rectum, because a lot of the time the PR bleed indicates there's a mass in the rectum. Not all the time, could just be diverticulitis. If there's a concern about stability, it'll be wise to reverse the anticoagulation or give them blood or fluids. But your colleagues can answer that. I think Dan Tyler just joined in. Hey Dan, we'll come to you in a little bit, buddy. We're just a little bit behind right now. Let the surgeon know when there's simple bleeding. If it's not getting better, let them know again, as they may want a CT angio to find out where the source of the bleeding is, to see if it's amenable to embolization, if they need to operate on it. It's rare we take a patient to theaters because of PR bleeding, but PR bleeding is definitely the surgeon's domain. So definitely refer to them when you find that. After you do a basic assessment, let them know and get a management plan for them. Largely conservative, generally going to be a flexi-sig as an outpatient. Pancreatitis, not going to get into it. It's people generally don't get them in hospital unless you did an ERCP, at which point you're looking after this patient and you're on the gastro team. So that's how you'll know what to do with pancreatitis. Just remember, do your A to E's, send up amylase with it with the rest of the bloods that you do, and feel comfortable giving these people fluids because they get very leaky, they get very edematous, and that doesn't mean there's fluids in their vessels. They could just be leaking that into the interstitium. Diverticulitis, it's unless it's a complication, I wouldn't class it as an emergency either. It's basically infection of the diverticular disease in the left lower quadrant. So sepsis, same risk of the rest of abdominal infections, perforation, what have you. If they're peritonitic, you might want to get a CT scan. If you think the infection's from diverticular disease, the infection is diverticulitis, then you refer to surgeons just so they can know about them. But I wouldn't class that specifically as an emergency unless they're septic. IV fluids, analgesia, antibiotics. All right, we're going to the next question. So this one, most people said no. I would agree. And the leaderboard has JP at the top right now. Good stuff. Oh, F1 hopeful getting up there. Right. Question 5. Classically, how many P's are there in acute limb ischemia? Fatima, I'm not gonna bring you in on this one. Don't worry. But while you guys have a think of that, let me start that question up. Don't worry, Fatima. I'm not gonna bring you on this one. It's okay. We're running out of time. While you guys think of the number of P's to indicate acute lower limb ischemia, let's talk about the rest of the stuff. AAA, unlikely, generally more likely they'll present with this rather than it'll happen during your admission. DVTs generally are medical rather than vascular. PEs, same thing, generally medically treated rather than vascular. There might be complications that vascular guys get involved with, but that's not the initial management. So AAAs are thought of as a silent killer because they show up as a lot of different stuff. It's like an unexplained abdominal pain. You may not always feel that pulsatile mass. Things that might clock you onto the fact they're having a ruptured AAA. Previous CT scan shows an aortic aneurysm already. Depending on where the aneurysm is, they might have lost blood supply to the gonads, so testicular pain, lost blood to the kidneys, so AKI, lost blood to the femorals, so limb ischemia, both sides, both sides or one side it could be. If you think it, you get a CT scan, let your bosses know because you'll need to talk to the vascular surgeons, and your bosses probably need to have a chat with the patient as to whether or not they want surgery or not. They might not. If the patient, because the surgery itself is very risky, they can die from the surgery. So they need to have a chat with the patients. Do you even want surgery? If they say, look, I definitely don't, then you can probably save them a trip of going to another hospital or transferring to another ward and just let them be peaceful. But that's between you and your bosses. I'm not saying that should be how you treat all patients. Right, acute lower limb ischemia. It's rare. I've only seen it once. But it can happen to your patients because they are pretty morbid. They'll generally be quite morbid already if they're older. There are 6 Ps. Not all of them need to be there. Some of them quite late stage signs. So pain, pallor, paralysis late stage, paresthesia, so loss of sensation early stage, pulselessness, and a pretty cold leg or perishingly cold leg. Maybe the AAA causing obstruction to femoral. So exclude AAA. And assess for the 3 pulses in the lower limb, behind the knee, dorsalis pedis, and behind the medial malleolus. And if you can't find them, then even if you can or can't, let the vascular guys know. And it's a time-sensitive one again. They need to get there quickly to try and see if they can save the limb. They might ask you to do a heparin infusion while you wait. If that's the case, ask them specifically for the dosing and the rate and what have you, because it's time sensitive and you don't have time to be faffing around trying to think what is this dose or what have you. Just ask them, they probably know better than you do. Right, urology. So 4 things with urology. 1, retention. Patients feels like they need to pee but they can't. Get a bladder scanner. The bladder scanner sometimes finds ascites and thinks it's a full bladder, so keep that in mind. Put the catheter in. I have 3 tips there. That's a Tiemann tip, which is curved tip. That's a Foley tip. That's the normal one we use. 3 ways are with hematuria. I'll talk about them later. If you're having trouble getting this tip in, this curved tip gets into the prostate a lot easier in men. So, and they're kept in theaters whether you do urology. So put that catheter in. If there was hematuria before the retention, then it might be hematuria that's causing it, clot that's causing it. So put a thick 3-way. I couldn't find a thick 3-way. Those Foleys aren't thick enough. They're generally also a bit more firm as well. Put a thick 3-way in. And with that one, so with normal retention, you'll just take out a sample, send it for MCNS, measure the residual volume, which is how much comes out the bladder, and they'll eventually get talked during their admission or later in the clinic. With hematuria, you've put the catheter in, you push 60 mils in hard, you pull it out, push it in, pull it out. Your job is to break up the clots to try and suck all the clots out. When it starts running without clots, you set up irrigation, let it go, let the urologist know. If you put 2 to 3 of those syringes in and you just can't get them out, and you've tried doing maneuvers where you move it around a bit, call the urologist. They might have some tricks in their bag to help you out with breaking up those clots, or maybe they just have to get involved themselves. If they're losing blood, resus with blood. Pyelonephritis with obstructing stone. This is something that people go to surgery for overnight. Obstructing stone, maybe you can wait till morning. Pyelonephritis, if it's managed by medics or sometimes urologists. But if there's both together, they're febrile, they had urinary colic or ureteric colic, sorry. You did a CT scan, found an obstructing stone, signs of obstruction on the CT, signs of inflammation, urine dip is showing there's an infection going on. They're febrile. You can assume it's pyelonephritis with obstructing stone. That is something that people go to surgery overnight for. So that is something you definitely have to refer to urologists as quickly as you can. Probably IV fluid resus, analgesia, and antibiotics while you wait. The antibiotics won't work because they can't penetrate the stone well enough, but they can help stabilize the patient a bit. Last one, testicular torsion. Not going to get into it too much. Your patient's going to be 80, not 18. So the chance of them getting torsion is a lot less. The testicle survives for around 6 hours after pain. So if it's longer than that, then the testicle is probably dead. There's going to be a whole host of other differential diagnoses for testicular torsion. But if you're thinking of testicular torsion, I find it tough to diagnose myself at this point. So I would have a chat with your bosses. You're looking for bell clapper signs. So instead of the testicles being like this, one goes like that. It's higher, markedly higher than the other, and the cremaster reflex is absent. But if you think it's testicular torsion, let your bosses know. Neck fash, Fournier's gangrene. Last two things. So very time sensitive issue. General surgery is involved unless it's around the scrotum, which is Fournier's. So then it's urology. They need to go immediately to theaters for debridement. It's not just a bad skin infection. But it is a really bad skin infection that's gotten really quite bad. But it's not just that. There might be some surgical emphysema. The skin may not be black. It may not have gone necrotic. It'll just be red or really dark browny, dark purple. They may start losing sensation if the skin starts dying, but if they haven't lost sensation, it's still early stages. There may be something called dishwater soap coming out from some sort of sore or something. That's good indication this is neck fash. They'll be very septic. They need to IV fluid resus, antibiotics, analgesia. They need to go into theaters, basically. Last one, paraphimosis. Someone's done a catheter and hasn't put the foreskin back again. 4 tips to fix it. Number 1, squeeze the glands, try and get the blood out of it so that it can make itself smaller so it can slip over. Number 2, put ice packs on the glands again just to bring the and around the foreskin just to bring the swelling down everywhere. Number 3, put your fingers like this on the glands and squeeze the glands between them so you're squeezing the blood out. And then put the little tips of your thumbs underneath the foreskin. Use your other fingers to loop the foreskin back over the glands. Number 4, use Optilube to try and help any of those motions. That doesn't work, immediately call the urologist, because if they lose the head of their penis, it's going to be very distressing for them. Right. We got a mad dash at the end because I know I'm running over. I'm very sorry. Okay. This was the last question. Most of you guys got it with 6 Ps. Good job. Last question, guys. Who's at the head? F1 hopeful. That's right. Good stuff. Last question. You're on the ward round. Your boss, your consultant asks you, do you want to be a surgeon? Hopefully through med school you've learned the correct answer to this. There are 2 possibles. And that's basically it. That's my talk done. Fatima.
Yep, I'm back.
All right, mate. I'm done. I'm talked out. We'll look at this in a sec. But do you want to say anything else?
Nothing to add to what you've said. Obviously, you've given us a lot of good, useful information and tips. I've learned a lot, definitely. Just before you have the quick talk from the BMA, just remind you guys that we really appreciate your feedback. Please send it over to us. You can use the QR code or the link. We'll put it on the chat as well. Like I said, we're trying to continually improve these every week. You know, you've seen we've tried to act on the feedback that you wanted, some polls. So, you know, did you think it worked? Any other improvements? Anything you liked? It would be very helpful for you and also for us. We also need it for portfolios and things. So please send us some feedback. And then I think we can do maybe the questions after Dan. Yeah, maybe.
Sure. Let me just so by the way, the answer to that one is, as you all know, you say either yes or possibly, just so that you can still get to do stuff in every application, everything you do. And the winner, by the way, is F1 hopeful. Good job. Thank you very much. All right, Fatima, I'm going to go mute and listen to Dan's talk. Thank you.
I was F1 hopeful all along. No, I'm joking. Okay, I cannot share my screen while the other participant is sharing. Okay, I'll just wait my turn. Okey-doke, looks like I'm on. Okay, should be able to see that all good now. I think so. Hopefully there's been a few links posted in the chat. So basically, and there's a QR code on the screen, obviously. So basically, if you sign up to hear from us, I'm from the BMA, by the way, using the QR code on the screen or the link in the chat, we'll send you sort of a free digital support back. It doesn't mean you're signing up to membership. It's just a free support back from us to you, regardless of whether you're a member or not. So that with that, you'll get sort of an employment guide, which will be useful looking ahead to F1. We negotiated the contract, so we know what should be in it inside out, and this guide sort of breaks that down. You'll also get sort of our ethics toolkit and some other bits. Again, doesn't matter if you're a member or not. It's just a free sort of guide from us to you. This time of year, you'd usually see us out, and we'd have lots of freebies and pens and all that kind of stuff for you. But because we can't be there, it's just another way of us giving you some stuff. So anyway, the QR code is going to be in the top corner throughout my little bit. If you haven't done it yet, you can do it while I'm talking. I don't mind. And yeah, so cracking on. So I'm Dan. I'm from the BMA. I'm just going to talk to you really quickly about membership. You may have heard me speak before, so I'm sorry if you have. I'm sure you're all members, or most of you are, or you've been a member at some point. So you know pretty much what we do and what you sort of get as a member. So treat this as a little bit of a refresher, and I hope also you might find out something new. So we are the trade union and professional association for doctors and med students in the UK. We act as the voice of the profession, representing you individually, locally and nationally on all the issues that affect you. So we get this confusion quite a bit, but we're not an indemnity company, so we're not like MDU or MPS. We don't deal with patient complaints. We're here solely to look after you, your working conditions, so things like your pay, your contracts, your well-being, and also your professional development. So we understand the sort of things you might encounter, particularly when you become an F1, and we can give you advice and support on any issues that you might face. So this can be anything from working hours to relationships with senior staff, or any responsibilities you have that you're not necessarily comfortable with. So just keep us in mind. We can take some of the pressure off you if you're facing anything you feel you need support with. We've seen most things before, particularly for F1s, and there's not much that we can't help with. We have relationships with everyone, every trust in the UK, and we have employment advisors and industrial relations officers based at every trust, so you'll always have someone in person that you can speak to. Not so much at the moment, but soon enough. So yeah, we're here if you want to reach out and there's anything you need help or support with. So very important thing that you're going to need soon. You may have heard of our contract checking service, which can save you some time and potentially quite a bit of money. So yeah, probably the key tool of ours that you'll use this year. So we will check your contract within 5 working days, comparing it to the national model that we negotiated. And if there's anything wrong, we can help get it sorted out. So trusts don't always mean to, but they can slip in sort of extra things here and there, or change the wording to mean the opposite of what it should be. We've seen it quite a bit. So we just want to make sure your contract's correct and you're getting paid what you should be. So scarily, no, it's not too scary. I don't scare you. 20% of the contracts we checked for last year were incorrect. So 1 in 5 of the contracts that were sent, it's way too high a number as far as we're concerned. So it's good to join us, be with the BMA, and let's check it preferably before you sign it. I can say at this point, membership will be the same price it is for final year students until October. So at least even in July, you'll still only be paying £3 a month to be a member of the BMA. But I'll get on to more of that in a minute. We can also check your rota is compliant. So use our rota checker. So with that one, it's sort of an online tool where you put in the information about your rota and it will flag up to us if wrong. But again, it should be pretty standard, so we hope that you won't have any issues. As you guys are obviously finding us at the moment, you're actually eligible for the weekly subscription to the BMJ, so the proper doctor version. So you could be getting this every Friday if you're already a member. You just, if you're not getting it and you would like it, just give us a ring on our general number or an email, and just say, this is my address. I just want to make sure that I can get this from now on, because it should be free to you, but it's an opt-in thing. You can also stop receiving the paper copies if you're getting them, and you can just, because you guys have all just got access to the BMJ app anyway, so you can just read the copies as and when they come out on your phone, and all the old copies are on there as well. Being a member, you also get access to our clinical and non-clinical tools. So I'm sure you've heard of BMJ Learning. So it has over 1,000 clinical and non-clinical modules. So there's a lot of good stuff on there, which is good for helping complete your e-portfolio when you begin F1. It's all very interactive, and we keep it up to date. And there's also lots of sort of audio and video stuff to keep you sort of more stimulated. For each module we do as well, you can print off a certificate as proof of learning, which helps. And then obviously later on, when you're sort of after CPD points, not so much in F1, but it's a very useful way of racking them up. BMA Library has thousands of ebooks and journals, plus research services which you can access from anywhere. Obviously, it's still closed at the moment due to COVID, but you can access this sort of online books instantly through our website, so through your phone or a laptop. And we have a series of webinars free for members through the year as well, and they're on lots of topics. And if you can't watch it live, you can always just watch it back on demand. Very early to be thinking about this perhaps, but if you're thinking about your specialty options, we have a specialty explorer tool which helps you get a bit of a picture of what suits you best. So that one, it's an online psychometric test which takes about 20 minutes to complete. It'll ask all sorts of work balance questions, then give you a pretty detailed report listing the specialties that suit sort of the answers that you've given. Very easy to use, it covers all specialties, and the reports are always very thorough, lots of analysis and graphs and whatnot. So we have some wellbeing support services. So if at any time you feel like you'd like to speak to someone about your wellbeing, they're open 24/7, and that's to all students and doctors. So that's regardless of whether you're a member or not. So you'd have the choice to either speak to a counsellor or a peer support doctor. It is based on telephone. We offer video calls as well, and we're hoping to get back to face-to-face soon. And we'll make sure that you speak to the same person twice if it's more than a singular call. So again, free to everyone. Doesn't matter if you're a member or not for our wellbeing services, and obviously it's completely completely independent of the trust. So yeah, if you're, I'll just wrap this up very quickly. If you're not currently a member, there's an offer because I'm obviously invited along today. If you join using the link on the screen, the QR code on the screen, or I think they're in the chat now as well, or yeah, all the comments, you'll get a £10 Amazon voucher. So this works for first-time joiners or if you're rejoining, and obviously you're free to leave and come again as you wish. But yeah, so only if you use that link though. So if you go off to the website now and do it, you won't get the voucher. So yeah, £3.66 it will remain for everyone until October, and then it goes up to sort of £7 after tax. So yeah, if you don't quite feel ready to sign up, that's absolutely fine. But again, going back to what I said at the start, you can use the QR code on the screen, and you'll just sort of sign up to be kept in touch with us, and we can sort of send you timely messages, just sort of things that you should be looking out for. Okay, doke, that's it from me. Thank you for sitting through my bit.
Okay, great. Thanks, Dan, for that. And thank you, Fatima and Ab, for a great presentation. I think it was really informative, and I'm sure we all learned a lot. I'm not sure, we're running a bit late, so sorry. But Fatima, were there any questions that we haven't answered on the chat?
There were a few. I don't know how much more time can we afford?
If there's any that have come up more than once, maybe we can quickly run through them. Otherwise, guys, I'll post a link, an email address on the chat. So if you have any questions that haven't been covered, you can just send them to that email address and we'll be sure to reply to you with an answer.
Okay, I don't think anything's kind of been repeated. There were just maybe 2 or 3 questions.
Send me 1 or 2. Let's just do one, huh? Do the meanest one. Do the meanest one.
I'll just ask the first one actually that was asked. So it's just to clarify, someone said, wouldn't you consider C-spine injury before securing the airway, i.e., you know, if you knew that there was a C-spine injury or that it was likely, you wouldn't do a head tilt chin lift sort of maneuver when you're securing the airway. So just to kind of make it crystal clear where exactly C-spine, considering C-spine immobilization is.
Cool. So the way it works, in as long as it hasn't changed in the last couple of years, the ATLS, when you walk in for a trauma, you walk in with your hands like this so you can secure the head, and you ask the nurse immediately to put 15 liters on the patient, okay? And then you go and you try and do some airway maneuvers while keeping the neck stable, and then you go to assess the C-spine, because as long as you immobilize the neck, you're not risking severing it. But at the same, so they're not, so, but if you move the neck, then you could kill them. But if you don't do anything, the airway can kill them. So you don't do any airway maneuvers like sniffing the air, what have you, that can compromise the C-spine. You can secure the C-spine, but you will wait until after you do the airway to actually assess, is the C-spine safe?
Yeah, I think that was important that you made the distinction. Kind of when you're doing the airway, you're already kind of taking into account that there might be a C-spine injury, but you're not necessarily assessing what the injury is until after
You assume
that.
there is until afterwards.
Exactly. Yeah. Janvi has popped up. I think she wants us to wrap it up.
Sorry guys, not enough time for more questions, but I've put the email address in the chat. It's info@mindthebleep.com if we haven't covered anything you wanted to discuss. One more shout out for the feedback, please, if you could fill that in. Again, the links and the chat. And I think that's it. Thank you again, Ab and Fatima. And hopefully you guys can join us next week for our webinar on hypo and hyperkalemia. So it'll be at the same time. But thank you. And
it's been great fun. Thank you very much. Bye, guys.
Thanks, guys.